Hi, everyone. Thank you for joining us today. I do see that we have some more people joining right now. Thank you. All right, so right now we're going to get started with the webinar. Kevin?
Hi everyone. Thank you for your time today. Thank you for your attention to this very important topic. And most importantly, thank you for working for the organizations you work for giving back to the community, and for the patients you impact. We have a really good session for you today. Preventing chronic diseases, eliminating obstacles to healthy living. So I'm going to let Fide kick everything off, and then she'll bring it back to me.
All right, thank you so much, Kevin. So before we continue, this is just some background information about NCHPH. The mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing a range of training and technical assistance. NCHPH is a project supported by the Health Resources and Services Administration, and it's also a national training and clinical assistance partner that is 100% financed by this grant. And the information presented today are those of the author only. So for today's speakers, my name is Frida Pineda Sandoval, and I am the TTA manager here at NCHPH, and I will be helping to facilitate and co-moderate today's webinar. And with us, we also have Dr. Kevin Lombardi, who is the manager of policy research and health promotion at NCHPH.
Hi, Fide. Hi, everyone. So I'm Dr. Lombardi. I'm a medical epidemiologist. My training is in medicine, in internal medicine. I did my medical degree and Master of Public Health at the George Washington University, residency in Danville, Virginia. I now study medical protocol compliance. I study the implications of SDOH on medical practice, and I study readiness for value-based care for health centers. In addition to that, I'm also the thesis advisor for an MPH student who's facilitating our session today. So throughout the session, we'll be teasing at some epidemiological concepts as we prepare ourselves and Fide for this topic. Back to you, Fide.
Thank you. Thank you so much, Kevin. All right, so here we have some additional information about the health centers that are close to public housing. And then according to 2022 health center, HRSA's health center data, there were over 1,300 FQHCs that served to 30.5 million patients. 483 of those FQHCs were in or immediately accessible to public housing that served to 6.1 million patients, and 107 were from PHPCs that served to over 935,000 patients back in 2022. And then this is some public housing demographics data. As we can see here in this infographic, back in 2022, there were 1.5 million residents that lived in public housing, 2 persons per household, 91% were of low income, 32% were female-headed households with children, 38% were disabled, and 36% were children, with 19% being elderly. And then in terms of race and ethnicity, 52% were white, 43% were African American, and 26% were Latinx. And now, without further ado, we'll pass it on to Dr. Kevin Lombardi.
Okay, so welcome back. So just a little bit about how the session format works here. I will be going through all the points of the learning objectives and using a specific format. We'll be trying to view the concepts epidemiologically, from the patient perspective, and from the health center management perspective. As we tease out our concepts, there'll be a couple of discussion questions, 2 of them. The way we'll do that is I will ask the question, and we'll ask you guys to throw your answers into the chat. Fide will then select those, and we'll discuss the topic more. But as I mentioned that, it's important to emphasize really the importance of that. The colleagues that you have on this webinar are the best asset that TTA provides. And the discussions, I think you'll find the more you engage with them, the more you get out of the session. So next slide, please. So my role at NCHPH is one of them is to manage the research. So I personally look over all of these citations myself. All the underlying research, all of the recommendations are reviewed by myself and or staff. So that is a quality guarantee from me of what you're getting. All of the citations will be linked, and I really encourage you, if you see something that's interesting, read the full paper with colleagues and discuss it. One of the best ways to get things to move in the direction you'd like at your institution is to show ideas and share ideas. Next slide, please. Okay, so the social determinants of health is a concept that we will be applying as an epidemiological concept. Through this, we'll be looking at the person's individual medical issues from the various social determinants and how they interact with them. So this will be coming up again soon. Yes, and full links for those of you who are interested in furthering your knowledge of the social determinants of health as a standalone subject. The WHO's conceptual framework is a great way to add to that knowledge. Links on the bottom left. Next slide, please. Okay, Fide, poll question.
Yep. Thank you, Kevin. So now we just want to know a little bit more about you and who is joining us today. If you can please provide your response and let us know which best of the options that will be launched in the poll is your type of organization. All right. Thank you, everyone. And as we can see here, most of you are joining us from nonprofit organizations, followed by health centers, PCAs, and public housing agencies. Thank you so much.
Excellent, diverse group today. Okay, so just pop in some more details into the chat as we progress. Let's hear what your health center is and what your role is. This is part of our process of understanding you and leveraging the diversity of your colleagues. Next, so please throw that into the chat when you get a moment. Next slide, please. Okay, so I'm breaking this down into arguments. And the first one is going to be that HUD-assisted families are more likely to experience chronic disease than members of the general US population. Let's go to the data. So here's our table that shows us the difference of these three populations as follows. On the left, we have all patients that go to FQHCs. This is from a survey of all FQHC patients. In the middle is the HUD-assisted group, vouchers, and so forth. And on the right is public housing. Next slide, please. What we find is that our HUD-assisted residents and residents of public housing are more likely to be diagnosed with hypertension. Next slide. They're more likely to be diagnosed with asthma. And next slide. And other data has indicated a variety of other chronic diseases as well. But that's just from the freshest data from FQHCs. Claim 2 for you. Chronic diseases interact with each other and with the SDOH to impact patient outcomes. And what we're going to do is kind of take a case and take it from the patient level and take it up. Fide, next slide, please. So we're going to start with Mr. Jones. So Mr. Jones has 1, 2, 3, 4, 5 chronic conditions, and they happened, and he was diagnosed with them in that order. Fide, could you please go through them, starting with 1 and heading to 5 and tell us what he has.
Sure. So Mr. Jones is a 55-year-old male. He was diagnosed with congestive heart failure in 2017, and the result of 30 years of poorly controlled hypertension was complicated by cigarette smoking.
Okay, that's
And
number 1. Number 2.
And then in the second condition, Mr. Jones began to experience bouts of acute pulmonary edema in 2018, diagnosed with chronic pulmonary edema in January 2019. And then in the third condition, he went on SS disability in May 2019 and started struggling with depression in June of 2019. He was diagnosed with major depressive disorder and in September of 2019. And for the fourth condition, after his diagnosis with CHF, Mr. Jones began to experience kidney damage. He was diagnosed with CKD3 in 2020 and CKD6 in 2021. Due to years of cigarette smoking.
I've gotten my Roman numerals wrong, but that was 4.
Oh, 4, okay. And number 5, due to years of cigarette smoking, in December of 2023, Mr. Jones was diagnosed with urothelial carcinoma.
Okay, so we've just looked at the span of 17, 18, 19, 5, 6 years of patient health outcomes. You just read this story. What, from a epidemiological perspective, what do you think about patients like Mr. Jones?
I'm thinking that he has a lot of multiple conditions that are affecting him at the same time. And then there has to be a bottom line issue that is causing him to have all of these issues happening at the same time. So I think just investigating a little bit further into like what are all of the other factors that are affecting him would be something to take into consideration when evaluating him.
So Mr. Jones is like every third patient in an ER shift at 2 in the morning. He's someone that you'll see frequently in the emergency room because of the various chronic health conditions they have. And you become very accustomed to seeing these patients, patients like Mr. Jones, especially when they end up trickling over to your primary care practice. So patients like Mr. Jones are very common. In fact, data tells us about 9%, 8.7 to about 9% of Americans have 5 or more chronic health conditions. But the story that Mr. Jones lived is very common, and that's with initial uncontrolled chronic issues, hypertension, cigarette smoking, maybe some hyperlipidemia or other predisposing conditions lead to an initial serious chronic health condition that in the end leads to the others. And keep in mind that the number 5 as well, also connected. Bladder carcinomas are deeply connected to smoking use. So all of these health conditions are connected for this patient. Next slide, please. Okay, so here are our conditions for Mr. Jones. We've got 1, CHF. We've got 2, chronic pulmonary edema. We've got MDD. We've got chronic kidney disease, and we've got bladder cancer. Next slide, please. And here's sort of the timeline of events here. He starts with the congestive heart failure, and then because of the congestive heart failure, it's very common for these patients to experience pulmonary edema because all of the heart from the blood that doesn't get through the heart is backing up. So acute pulmonary edema once or twice a year is pretty common in these patients with uncontrolled congestive heart failure. But as that becomes more serious, it becomes chronic in nature, and the patients are constantly dealing with edema that needs to be managed very carefully. It impacts patients' lives significantly because they need to alter their daily habits and their diet substantially. Depression is a common byproduct of congestive heart failure. A large percentage of those diagnosed with CHF end up having depression within 5 years. Kidney disease. Another common byproduct of serious CHF is strain on the kidneys. So this patient developed CKD3 and then CKD4. And then a bladder cancer diagnosis that came in, I believe, 2022. So a difficult 5 or 6 years for Mr. Jones, but a very common story. Next slide, please. So as I just discussed, these conditions are very well connected with each other. They may be linked to other predisposing dynamics and share those dynamics, but they also form a feedback loop. And what you'll find with patients with many chronic conditions is the more chronic conditions you have, the more difficult it makes the treatment, because it limits options, it complicates avenues for approaching diagnoses, and it complicates treatment plans. Next slide, please. So, I had some time. So I went ahead and looked at every single connection, every single feedback loop that would occur between these various chronic conditions. And what I found is there are quite a few. Each color comes from one of the different diagnoses and links to the others. And as you can see, almost every condition has some sort of connection with the other. And that can either be a good thing or a bad thing, depending on the health trajectory of the patient. But when the health trajectory is bad, that can also often make the patient get more sick, worse, and quicker. Next slide, please. So let's just look at the patient outcomes. And this is a graphical representation of what the epidemiological data tells us. So when patients have 5 or more chronic health conditions, and this can be any, but when I'm speaking about this colloquially, I mean at least one of them needs to be something like CHF, COPD, or so forth. These are patients that experience, in addition to the burden of the chronic disease, at times disability as well. So there's a significant overlap there. But when we look at the individual patient outcomes and appreciate the diversity of the types of people like Mr. Jones, what we find is I call it poor subjective experience, but and generally patients enjoy life less. They're less able to engage in the activities that they enjoy. Their social patterns disengage and at times atrophy, and that leads to just people being less happy. And we know that not just on subjective experience, what patients say, but on psychological literature as well. Risk of social isolation goes up for patients who have chronic conditions because of the mobility concerns that many often have. And an increased risk of injury makes that even more complicated. Those with CHF, COPD, they're at increased risk for infections. And these can often be very, very serious infections like pneumonia and so forth with multi-drug resistant organisms. These are things that are increasingly common. The economic cost of care burden for a patient like Mr. Jones is significant. In addition to the costs of care, of getting the care, the loss of productivity at work is something that they're going to experience almost immediately. Patients who have some condition like CHF have less energy and are less able to engage with activities in and out of the workplace in general. And this also leads to increased disability risk in general, both because of the condition and because of complexities due to the condition, like risk of falls. As you can see, the picture here just gets more and more complicated for Mr. Jones. In addition, loss of income can limit patient choices significantly, and reliance on social support systems can be difficult for patients. It can create social strain and create economic strain as well. Next slide, please. So when we have a health system that has multiple patients like Mr. Jones, the impacts are even more significant. And we all have patients like Mr. Jones because they're close to 10% of patients, period. So I've often had patients that have started with 0 diagnoses and left the office with 5 chronic health conditions. So patients are often undiagnosed or underdiagnosed and are in this category but don't realize it, or we don't realize it. But from a a public health perspective, from a primary care perspective, and a system-wide, what this leads to is an increase in cost in healthcare coverage, increased emergency department use, increased specialist use, increased strain on existing resources. The cost of care goes up. The cost of the chance of healthcare staff burnout increases and puts strain on the workforce. So there is an interest on both the patient and the health system level to make sure that patients like Mr. Jones experience the best outcomes possible. Next slide, please. So let's take a perspective from the social determinants of health. So we have this one patient with these chronic diseases, right? But we don't know anything about their life. So let's talk about that impact. Next, please. And this is kind of a fun way of visualizing the patient and visualizing the social environment that they live in, and kind of seeing where it interacts. So, so Mr. Jones is has only a high school education, has worked for as a contractor for most of his life. So his trainability for various industries is relatively low. So he might find difficulty without guidance. This is a patient that would do great for a job training program or something of the sort, especially considering that he has increasing mobility issues. So that's a great opportunity, low-hanging fruit there. So he is HUD assisted. Patients who are HUD assisted, if they stop paying their rent, they can lose their apartment and their voucher. One of the reasons it's great to have a medical legal partnership is that you can help patients stave off that, by the way. The CHF, COPD, conditions like this, they really the patients and what they can do. How often they can go out of the house, how often they feel exhausted. These are debilitating conditions. So what you'll find is after diagnosis, patients will be unable to maintain social relationships like they did pre-diagnosis. And that's often why we see depression as well. Next slide, please.
We also just received a comment in the chat, Kevin, by Samantha saying health insurance companies need to step up and pay for services in the home.
I think someone's cheating and looked at my slides. I think someone's cheating. Samantha, yes, here, and let's wait to our promising practices section so we can talk about the benefits of those. Before that, I got this fun problem. Late at night when I think of these things, 9 o'clock at night when I'm writing it, I call FIDE and I bother her and tell her. And one time I called her at 8:30 in the morning, and she gave me a hard time for that. So what I can say is there's a lot of thought that goes into these discussion questions, and we really want you guys to engage as much as possible because well, hey, look at the chat. You get some fabulous colleagues that connect, talk. It's a great opportunity to share ideas. You might like someone's comment, like it, share emails, talk, because we're all dealing with very similar issues in the clinic and out. The second part is the more one engages with the material, the more one learns. Not just my opinion, it's psychological research. So let's do it, guys. This question is sort of an intro public health question. And I'd love to get your insight. FIDE, could you kind of take over, please?
So the analysis of health center data indicates that 456 of your 3,999 patients have 5 or more chronic conditions. The national rate is 8.7%. And if any, what steps can be taken to improve this issue in your patient population?
We are going to take 2 minutes. Please, everyone, take 2 minutes, or let's take 1 minute to think of the question and quickly throw an answer into the chat. We'll make that 2 minutes. Thank you. And Fide, you're going to be the first, you're going to be one of the answers for this after we pick some participants. Okay, Fide, let's do it.
All right, thank you.
Wait,
So, all right. So based on my own experience that I've had with like
oh, you're out. You after the party. You don't.
all right.
Yeah.
And I,
We don't want you to ruin the experience. You know.
no worries. All right.
Yeah.
So
So
um
let's pick one if you don't mind, please.
sure, yeah. Dominic Davis, I'm going to unmute your line. If you can please just elaborate a little bit more on your response. And
Dominique, could
Dominic,
you briefly introduce yourself and tell us a little more, please? And tell us what you do, if you don't mind.
Hello, good morning. My name is Dominique Davis. I work for Mercy Housing, which is a national housing, affordable housing provider. Currently, I oversee our community health worker program, and I'm a licensed professional counselor. So my answer was to work on some of the health conditions where you might see immediate impact of like a health improvement, which is like a decline as far as being above the national average, to start to get some of those chronic conditions under control. So a targeted approach for conditions of the 456 patients that have things that can be like more easily remedied. So that was my thought.
So, thank you. Can I call you Dominique?
Yes.
So thank you. Yes. So 100%. But I got one more question for you. What do you think, if you had to pick a condition for Mr. Jones, that would be the first one, which one would you pick?
Oh, sorry. I'm not
You
looking
could
at
only
the
pick one. If it was one that was to be a main focus.
Oh, if it was one to be the main focus, um, mm, maybe, what is CHF? Is that the benefits right
That's
here?
congestive heart failure.
what is MDD again?
Major depressive disorder.
Oh, maybe 3, work on that one.
So
But
from a medical perspective, I focus on the CHF. The
CHF,
MDD, so CHF is deeply connected to MDD. And if I'm an internal medicine provider, I would focus primarily on the CHF because it's so deeply connected to the other conditions. But understanding yourself as one who oversees community health workers, the MDD, focusing on the depression, is certainly the thing that's most in your hands with this patient. So I appreciate the perspective. Thank you so much. And yes, so agree. The low-hanging fruits in your community are a great place to start. And what those are depends on your community. And often all it takes is a little a gander at your local data of your patient data to tell you what direction to go with that. Next, Fide, could we grab one more?
Sure, yeah. I'm going to unmute the line for Wendy. Let's see.
Wendy, good to see you. Could you
Hi, how are you?
good? Could you introduce yourself to the group and tell us what you do?
I'm Wendy Nugent Healy, and I'm a community health worker in Hardy and DeSoto counties in Florida. I work for Heartland Rural Health Network, and I do just about everything you can imagine a CHW would do. We assist people in applying for services such as Medicaid, Medicare, Social Security. We collaborate with other social service agencies to see that our patient is being provided with the best services that he can. We educate our clients on how to take their medications. In some cases, I may have had to actually portion out medication on a weekly basis for a client, and which assures that they are taking it at the right time. I have set cell phone alarms so that tell the patient it's time to take your morning pills, it's time to take your daytime pills, so on and so forth. But mostly we educate.
As in the trenches as it gets, Wendy, honestly.
We mostly educate. So we are there for support. And sometimes people don't have a support system other than us. So that's what we do.
So thank you for the perspective. So if you have, say these are your patient roles, and you have a lot of patients, I'm sure, that have more than 5 chronic health conditions, what are some steps that you could take to improve things for this patient population from a CHW's perspective?
The first thing I try to do is educate them on the diagnosis. I try to help them with their diet. I help them to understand why when a person, for instance, with congestive heart failure is told that your worst enemy right now is salt, that cannot be impressed enough, because as someone who does have that condition, I can guarantee that if I do not pay attention to my salt intake, I am going to end up back in the hospital. So I'm very up on trying to teach our patients, say with the CHF or diabetes, and how to substitute different foods and things for the sweets that they're used to. Education is the most important role, I think, that we play. Then we can look outside their individual education for other ways to help them, such as help them find their medical coverage if they don't have it. Help them find primary care providers who can sometimes stave off those emergency room visits. We do so many things, we wear so many hats, and each patient is an individual, and our jobs are totally unique for each client that we have.
Thank you for that, Wendy. And if anything, the value we should take from the last 10 minutes of conversation is of interdisciplinary conversations. As a physician in internal medicine, the CHW perspective is incredibly valuable to me. It gives context I don't have, and vice versa. Talking about patients like this and programmatic approaches is important. For those of you who are physicians yourselves or in management positions, many health centers have begun putting CHW representatives on boards of advisors, or having specific ways to communicate with their CHW staff and integrate their perspectives into health center management. because it's often one of the most accurate perspectives of the patient experience, other than that from coming from the patient itself. So thank you for that, Wendy. And Fide, I think we need to, for time's sake, go to the next slide.
Yep. Thank you so much. All right.
Okay, so for those of you, okay, yes, for those of you who know me, my system that I use when I'm talking about intervention, CHW level and SDOH intervention, is screening for the patient for SDOH in the clinic, and then networking them to a social service via referral. Next slide, please. And when I talk about CHW networking, there is a wide diversity of ways that CHWs do their work. This is sort of my chimera of all of them together based on what best practices are supported in the literature. There's a lot of different data on this, and I've kind of put it together for these recommended models, which is the coaching style dynamic and navigation system. And this is what's commonly recommended in papers that are validated on CHW recommendations. And my recommendation for you all is to base your systems on these best practices as well, and to investigate the best practices that fit the best for your organization. But next slide, a little context. So let's talk promising practices. So when we're looking at patients who have chronic disease, and we're generalizing about a very wide diversity of folks. So from a programmatic standpoint, it can be difficult without specifically focusing on a very specific condition. Patients with heart failure, patients with COPD, patients with HIV, patients with type 2 diabetes, so on and so forth. That being said, there are a variety of interventions that have what I think is just the best ROI for program interventions. So I'm very ROI focused with program interventions and SDOH support, because health centers are organizations that need to survive financially as well as providing healthcare. Financial health for the healthcare organization equals better financial health for everyone. So there are some places where investment in SDOH services for chronic care is specifically impactful, and this is data, not just my opinion, but it's data and my opinion, so it's even better. So one, investing in transportation networks. And you know, when I said this at a primary care association meeting a couple of weeks ago, and they look like this, like I'm not, you know, because that's expensive. But then when I mentioned the best way to do that often is to develop local partnerships, they started writing things down, because the most effective way to do that is through local partnerships. But as far as having the biggest impact on your system, transportation is one of them, and we'll go over the details of that in a second. Two, partnerships for nutrition access. Providing food is complex. There's a series of tasks that need to go into sourcing, buying, producing, and distributing food. And it's complex for health centers. There's a whole other set of industry knowledge that they need to understand to do this on a wide and large scale. For health centers that are interested in nutrition or improving nutrition programmatic access, but yet have not made those investments yet, and aren't in a place to make those investments, sometimes the best way is to get referrals to those local organizations and to integrate that into your CHW networking procedures. It's amazing to me how often folks, and by folks, I mean health center managers, and decision makers don't know about resources in their area. That's because it takes time to keep up with these and to make sure that you're integrating new updates into your referral networks. So my argument for you is to invest that time and to find local partnerships to fill gaps if you have them, before you have the conversation about investing in infrastructure. Home visits. We'll get a little more into home visits in a moment, but specifically for our residents of public housing, if you're at a PHPC, and you have a traditional public housing development near you, it allows a level of access to the patients that is just fantastic for their clinical care. It's better for communication. It's better for health. Better for compliance. It's better for access. So residents of public housing, it really present an opportunity with home visits to improve outcomes substantially on a community level. Next slide. And increasingly, keep in mind that increasingly how well we do on a community level, how well we take care of our populations is going to matter financially for organizations. And that's already started, and expect that to continue to start as the years go by and as we switch to more value-based models. And specifically with home visits. CHWs and LPNs, these are all three of these are validated studies that if you're interested, I would encourage you to look at. FQHCs have utilized CHWs and LPNs to perform home visits for newly diagnosed congestive heart failure patients, and it's shown increased compliance and better outcomes. Nurse-led home visits are used by health centers to improve hypertension management, excuse me. And these programs have showed better outcomes and better compliance in hypertension management. And the last one, excuse me, Peter, I've got my windows in front of me. Oh, the use of long-acting injectable antipsychotics is no longer a new phenomenon, but they really allow more flexibility in the treatment of patients' behavioral health conditions because you can focus it the administration during their clinical visits. So great new tool for providers in taking care of that patient population. Next slide, please. So yeah, some home visit data. So what we see, next slide, when we look at this table, is that residents of public housing use home visits at a much higher rate than the general population. This is from the 2022 Health Center Patient Survey, my favorite survey, and it's 2.5 times as likely. That's a huge magnitude. And I think that speaks both for the desire for the services, residents of public housing want these services, but I think it speaks to the ease of delivery of those services in certain public housing developments. This is happening more often because it can happen. And I think health centers have specifically looked at this issue and seen that this is a good investment for them on a variety of different areas. Patient outcomes, staff involvement in the community, adaptation to local healthcare changes or epidemiological changes, disease transmission. It gives you a pulse on the community in addition to giving access to those patients. Next slide, please. Okay, do you know what this is, Fide?
An evidence pyramid.
Okay, so kind of describe the general concept here, please.
Well, yeah, so basically in the pyramid, we can see the different types of epidemiological studies that can be done. And then we can see in the arrow to the left, this is the quality of information. So in the top tier, the best information would be gathered from a meta-analysis. Am I correct? And then followed by systematic review, the randomized control trials, cohort studies, case control studies, case series, and background information, which is usually primary information that would be gathered at the bottom. Yeah, and that would be like my overview of this. And I'm sure Dr. Lombardi could.
Yeah, nailed it. And what this means to a healthcare provider is it means the weight that you give to studies that recommend a given intervention. So when you have meta-analyses and systemic reviews and multiple ones, that tells you about the strength of that evidence and about what you can and can't do. So next slide, please. And it tells us specifically about how strong this one is. So investing in transportation. And so this is the best study of an SDOH program I've ever seen. It's large, it's a systemic review, and it looks specifically at transportation programs. And what they got was, let me just get to the slide for a moment. I'm getting there, I promise. What they found that, okay, so transportation support was offered within a CHW counseling system. So when patients were referred to social services, they were referred to a CHW, and those who needed transportation were networked to transportation for all of their clinic visits or healthcare visits as needed. And they were entered into this study. Entered into these studies. So specifically, the outcomes were as follows. And these are significant outcomes: improvements in cancer screening rates, improvements in chronic disease management, increased linkages to care, improved, and the last one was actually a surprise to me, improved maternal empathy. That means by providing patients who didn't have transportation, who needed it, with transportation, you actually improved maternal empathy in the population there. If that doesn't speak to the power of these interventions and often how significant they are, I don't know what will. But the thing about this list is improved screening, better chronic disease management, increased linkages to care. Those were all things that, in addition to improving patient outcomes, they improve efficiency for health centers. So this is like, in addition for being great for the patient, focusing on a ST or H intervention measure like transportation can specifically help these patients and help the health center significantly. And I don't know about you, but when I'm looking, if I have limited resources and I'm looking to invest in either my time, money, or staff into something, I'm going to do it in a place where I can get multiple benefits. So for those of you who don't have robust transportation and have considered growing it, starting it, you feel like you're good and you want to evaluate it, I really recommend taking a good look at it, because even just a small difference can help a whole class of people that you didn't even know and improve your outcomes significantly. And what's the outcome of that? More financial stability for the organization, much improved retention of staff, less burnout. So I really would like to compel you to focus on those small and simple areas where you can increase access, because they are always there. We can never spot all of them. And if you take a good look with colleagues that are in the know, it's often easy to see a route towards better community health in general. So have those conversations. They're also fun conversations to have. Next slide, please. So final case study. This one's fun. And so the last one was fun too. But so we may go a little bit over. So feel free to jump. And Fide's in her head is saying he didn't tell me he was going to do that, but now he's doing that. But yeah, I really want to get as much of this done as possible. So we're going to go over it. So Mrs. Caputa is a 47-year-old woman. I'm well known for misgendering patients in case studies, who presents for a wellness exam. Her last exam was in 2020. She has a past medical history of hypertension, hyperlipidemia, CHF, and type 2 diabetes. The patient has a behavioral health history of depression and generalized anxiety. Here is our BP from today. 178 or 98, heart rate 78, respirations 26, hypertensive, tachycardic, tachypneic. We've got records from 2020, and the records say vitals were much better. They were controlled. We have an A1C 7.0, drug screen pan negative, and we've got medication, what the medications say they were, but we have no idea now. Next slide, please. So this health center has a SUH screening protocol. Great job, guys. And so what they did is they collected this information, which was super helpful in the exam room. What it was is just basic SUH screener, and we patient response here. So we've had skipped meals because of hunger at home, lack of money to buy food, worried about homelessness, no trouble paying for utilities, trouble paying for a ride, need daycare for kids. Yes, next slide, please. Unemployed or without regular income, yes, and needs help finding a job. Okay, cool. Next slide, please. Okay, so Mrs. Caputa is seen in her exam room by her provider, who does a full examination and focused interview. So full examination is like a head to toe. They've been here since 2020, so you want to get full physical examination, and a focused interview is based on things you find during that full examination and based on this SDOH screener, which is a valuable tool that providers love to be able to have. But Mrs. Caputa is a single mother of two, receives $750 a month in child support. She was diagnosed with CHF in an outside facility in 2022. So she had CHF, we didn't even know. We didn't have any records of it. We're just finding out now. She struggles to pay for her medication, is not sure of her whole list of medications, and has missed multiple cardiologist appointments since 2022. This is a story as old as time. This patient is, I've seen them 1,000 times in every shape, color, creed of human that you can imagine. This patient happens, and CHF is a very difficult condition to control. It's very difficult. So these patients struggle, and if they're struggling to take care of their CHF, trust and believe there's going to be more problems down the pipeline, and they come in a very predictable pattern. Mrs. Caputa previously worked 30 hours a week as a convenience store clerk until 2022, but has steadily cut down hours due to inability to stand due to swelling in her feet, CHF. Mrs. Caputa uses your state's Medicaid insurance. Mrs. Caputa is provided with samples of medication for chronic conditions and provided with follow-up and specialist appointments. Assume that has been done appropriately. The provider also requests a referral to social services for SDOH support due to Mrs. Caputa's SDOH screener. Next slide, please. I always look at my own screen and don't do my own slide. Okay, so social work refers Mrs. Caputa to a community health worker for navigation. We send Mrs. Caputa to a Wendy. And my question for you, and we're going to take the last two minutes to do this and a couple of responses. What sorts of SDOH resources should the CHW consider for Mrs. Caputa? And just take a minute to do that. I'm putting 45 seconds up. So Fide, my perspective, my theory is that because CHWs need to be so creative with the resources they give people, they're creative with their answers as well.
Yes. Of course.
I say we give them a couple of buckets of paint and say what they do to the inside of your office.
Right, yes. I'm sure they would have some very creative responses here. Right?
Oh, timer.
It sounds like, I'm not sure if Dominique or Wendy, are you trying to provide a response?
30 seconds.
It sounds like the line keeps cutting off, just letting you know.
Okay, we can't type that fast.
There you go.
One of the first things I do is make sure I know what all of her medications are. I would probably do a home visit, help her go through her medications, make her list, make sure she understood how to take them. We would make sure that she has a PCP and transportation to get there for whatever appointments are going to be coming up. if she has been assigned to a specialist, we would try and help find the most available specialists that she may need, such as a cardiologist, because not all cardiologists happen to take Medicaid. If Medicaid is the issue, you really do have to look around, and sometimes they are referred to cardiologists that do not take part in the Medicaid program. So we have to really examine what her actual access to the supports that she needs is. And then we will start collaborating and advocating within the rest of the community. Done.
Thank you, Wendy, for your response. And that is correct. I think we just lost Kevin, unfortunately. Maybe there must have been like a misconnection, but I'm gonna read out another response that we got in the chat. Rebecca said, I would review her medication against her Medicaid approved list and go with her to speak with a physician. That is another great response as well. Well, thank you so much. Unfortunately, we lost our other speaker, but we're right at the end of the webinar, and we thank you all for your attendance today and your participation. If you have any follow-up questions, you may always reach out to us at our contact information here. You may contact Dr. Kevin Lombardi at kevin.lombardi@mgt.com or myself, fide@mgt.com. And this is one last reminder to please complete our post-evaluation survey. Your feedback will be greatly appreciated. And we look forward to seeing you in our other upcoming sessions that we're going to be sending you some information about other TTA sessions that we have coming up as well. Thank you so much and have a great day.